you for having us. I'm going to talk today just a little about the changes, some of the most common changes that we experience as our eyes age. I've been with Dr. Collins now for about 8 years. I've been in practice for about 10. So this is certainly a passion of mine. And we do a lot of general health exams. We work with macular degeneration, glaucoma patients, as well as specialty contact lens fits. And my personal passion is dry eye. So we'll look at that a little bit today as well. So let's get started. These are the doctors. A much younger version of myself on the left, Dr. Rosen in the middle, and Dr. Collins on the right. And we'll start by talking about cataracts. So cataracts are a very common thing that we see in just about everybody. I like to say if you live long enough, you're going to get a cataract. It's unavoidable. Over 3 million people are diagnosed with cataracts and receive surgery a year. It's actually the #1 surgical procedure in America for people over the age of 60. Over the last 10 years, technology has advanced tremendously. So we've seen huge leaps in vision correction, speed of recovery, and now today it's safer and faster than it's ever been before. And we're doing this procedure on younger and younger patients. And we're doing that because insurance has changed some of their requirements so that instead of waiting until the cataracts are dangerous or at end stage, you can actually do it as soon as your vision is affected and your lifestyle is affected and get you back to seeing and feeling your best. So what is a cataract? The natural lens inside the eye slowly turns into a cataract with time as that lens becomes opaque and loses its natural flexibility. Its natural flexibility is what allows us to see from one end of the football field all the way to the tip of our nose when we're 8 years old. And after 40, we all start needing cheaters. And we find that that flexibility goes away and we become more and more dependent on reading and distance glasses. As we continue to age, in addition to losing that flexibility, the lens becomes cloudy or opaque. And that cloudiness is a cataract. Our eye functions like a camera. So the lens is made to be flexible to focus the light or the image that we're looking at on the back of the eye. As the cataract develops in the eye and becomes opaque, instead of focusing the light into a nice sharp image, it instead scatters the light, increasing glare and halo and decreasing the quality of the image. So we see that bright colors become more dull. We lose the sharpness of the image quality. We find we need more light to read. Sometimes we have such blurry vision that it becomes doubled. And frequently we need to change our glasses even more than once a year. We'll notice halfway through the year that the new prescription we just got just isn't cutting it anymore. And I hear a lot, I just can't follow the golf ball. I don't know where it's going anymore. So how do we fix it? Cataract surgery is amazing. Decades ago, it was a terrible procedure. Have your head lodged between bags for a week or two after. Now, it's a very quick outpatient procedure. It's done under a local anesthetic, so there's no discomfort. There's also no risk of general anesthesia. And a tiny incision is made, and through that itty-bitty incision, we do the whole procedure, usually in between 6 and 10 minutes. Most people are back to normal activities the next day. Let's look a little more into this. We make a tiny incision, either with a blade or more frequently today with a laser. And through the tiny incision, we use an instrument called phacoemulsification. And that's just a fancy word for an instrument that uses ultrasound wave to liquefy the cataract. It's the same waves we use to image babies. So there's no pain, no impact. And once the cataract is liquefied, it's gone. And we insert into its place through that same tiny incision an implant that can correct your vision. The implant is inserted, rolled up almost like a fruit roll-up, and it unrolls in place, centers itself, and the vision is corrected. The incision is so tiny, it typically seals itself. So there's no sutures or anything like that after surgery. Then some of the newer technology on the market is the laser. And the laser we have is the femtosecond laser. And this laser not only can make the incision for the cataract surgery, but it can also open the bag that holds the cataract and actually break the cataract into pieces. By using the laser, we're able to cut down on the amount of energy used during the surgery and reduce the surgery time. So we're able to have faster outcomes, quicker healing time, less blur after surgery with this increase in technology. It's incredibly accurate and repeatable. We've been very, very happy with our laser. The implants we put in really give us a range of what kind of vision you'd like to have. And I think that's the most fun part of cataract surgery. You get to pick how you see. So of course we do a full health exam on the eye, and that sometimes does narrow down the choices. Sometimes you're just not a good candidate for certain vision upgrades based on the health of your eye, macular degeneration, things like that. We wouldn't put a lens into the eye that you weren't able to fully utilize. But if you do have generally healthy eyes, we have the ability to not only eliminate distance glasses, but significantly reduce or eliminate your dependence on near vision glasses, cheaters for up close, and also give you that great vision at the computer, the dashboard, that intermediate range. And these are the premium lenses that can correct your vision at multiple ranges. The basic lens, typically covered by a standard insurance, can correct your vision to some extent as well. It does not correct astigmatism, but it can improve your vision. And at the bare minimum, we're getting the cloudy cataract out of there so that you can see better, especially if we still need glasses, you'll still have more clear vision. When we talk about multifocal premium presbyopic lenses versus a monofocal or a more basic lens, we're talking about the number of points that your vision is clear. In a monofocal, you would have clear vision at one point, a monofocus lens. You'd still need glasses for reading and probably for the computer. In an upgraded lens, that will give you more points of focus. So we would call them a multifocal or an extended depth of focus lens. And these are designed to give you excellent distance vision as well as intermediate and near vision. And you would find that you really wouldn't need glasses. I like the analogy of walking into Publix. You'd be able to find your aisle by looking at the signs, pick up your box of cake mix, see the price on the rack, and also read the ingredients necessary in the instructions on the back of the box, all without glasses. So that's nice. It's really nice to eliminate the need to be constantly reaching for cheaters. With these lenses, you'd find, like in this image, you can pretty much see everything out the window for distance, as well as the nutrition and information on the can of soup and the ingredients necessary in the recipe. You'd find that you have a greater spectrum of activities. You'd be able to follow the ball for golf or tennis, from the ball approaching you, swinging the racket all the way out to your partner hitting it back. That summarizes what we do with cataract surgery. And just to say a few more things, downtime after cataract surgery is minimal. Most of our patients are clear, sharp vision within 3 to 4 days after surgery. You're certainly clear before a week later we do the second eye. So you're never out of commission, you're not down for the count, you're not patched, you're not on bed rest. You can resume your normal activities with very minimal restrictions. So it's a wonderful procedure that really restores our quality of life and vision. I'm going to transition into dry eye. And this is something that I'm passionate about because I suffered with it myself for years. And it led me to do some research with the National Institute of Health. And Dr. Collins has really supported me in leading a dry eye clinic here in the office to help patients with similar issues. So let's dive into this a little. Dry eye is really a disease having to do with the structure and function of the tear film. So you can have excessive evaporation or reduced production of tears, which lead to symptoms. And the symptoms can range from, mild irritation to severe vision loss, depending on the level of dry eye that you have. The tear film is shockingly complex. Instead of just being these salty, watery things that roll down our cheeks, tear film on the surface of the eye is actually composed of 5 layers. The top layer is an oil layer, which is secreted by our eyelids. The bottom layer is a sticky mucus-like layer that makes the whole thing stay in place. And the middle several layers are a combination of a watery layer called aqueous and some blended layers that hold it all together. Any Disruption in the thickness of those layers can cause symptoms and issues. The job of the tear film is rather complex. Not only does it protect us from infection by killing bacteria, but it facilitates simple things like blinking, lubricating the surface between the eyelid and the globe. And it is also how we get oxygen and nutrients to the surface of the eye. There are no blood vessels on the surface of the eye, so we have to rely on our tear film. As far as symptoms go, mild, moderate, and severe, ranging from some mild itching, soreness, periodic light sensitivity, but maybe once a week, maybe once or twice a month. As you get more severe, the symptoms become more prominent and more continuous. So then you start dealing with it every day, and then finally in severe, chronically. So you find your vision is reduced, blinking is painful, terrible burning of the eyes all the time. And I see patients at the full spectrum of this. It's nice to be able to catch it early. But dry eye is one of the most common things that we see. I think it's severely underdiagnosed. Over 15 million people a year, and I would say that number is probably low. There is a higher incidence in women than men due to hormonal shifts with time. And it is age related, but not entirely. It can happen, in young people as well. And I am seeing that more and more frequently with increased electronic device use. And as I said, highly underdiagnosed. So some of the things that predispose us to dry eye, certainly age. Everything seems to change a little with time. Changes in hormone levels, both estrogens and androgens. Allergies, environmental allergies are a big one. The medications we use can cause a reduction in our tear film production, as well as environmental stresses. So are you a contact lens wearer? Do you sleep with a ceiling fan? Are you on an electronic screen? How much do you sleep each night? And here in Florida, going from hot, humid outside to cold, dry inside, we see a disruption in the tear film simply from that, from our environment. So these pictures indicate what dry eye looks like to me. When I look at an eyeball with severe dry eye, these should be smooth surfaces. In the image on the left, the yellow dye used here under a blue light is showing clumping of the tear film as well as damage to the superficial layer of the cornea. The pink dye in the picture on the right is actually showing dead cells in severe dry eye where a layer of the cornea is so damaged that we would have to do some pretty extensive treatment to get that back. But the good news is, with diligence, we can get it back. So how do we diagnose dry eye? Really, it has to do with signs and symptoms. So having a conversation with my patient is of the utmost importance. When do you feel dry? Is it morning? Is it all day? Is it worse at night? Is it itching, burning? Are your eyes watering? So it seems like it's the opposite of dryness. And the signs are what I see when I look at the eye. I examine the tear film and all of its layers. We look at the surface of the eye to see if there's damage there. We evaluate the glands that secrete the oil in the lids, and also the function of the lids. Are the lids in the right place? Are they starting to sag or droop, or are they too tight due to other disease processes like thyroid eye disease? And we really get down into the nitty-gritty of why the eyes are dry, and then we can start to chip away one by one at the causes to make things better. So there's no foolproof single method of treating dry eye. I find that every patient really needs a tailored approach. Typically, there's not just one cause of dry eye. So it really comes down to what is your specific problem, or how many specific problems do you have that we need to treat. So we do a lot of testing in the office. We use different dyes to evaluate the tear film. We can measure how long your tear film takes to break down once it is stable, and that will help dictate the care. Let's talk a little bit about some of the common causes, and we'll start with allergies. These are a big offender, especially in Florida. We're in a subtropical environment. Things are blooming year round, so we're always dealing with dryness and irritation from allergy. What our environmental allergies do is they create a cascade of inflammation, and that cascade of inflammation disrupts the tear film. Those inflammatory cells infiltrate the tear film and cause instability within the tear film. And it can be a chronic problem. The more unstable the tear film, the more allergy can get in. So it really can become a snowball effect worsening. So I like to start by knocking the allergies out. That's the quickest, easiest way to get a little bit of relief. In our office, we do offer an allergy test. It is specific to the eyes, and it tests for the 60 most common environmental allergens in our area that affect the eyes. So it's a really customized test, but instead of shots to treat allergies, this test will yield results that we are able to formulate into a solution that you dose yourself with under the tongue for about 3 months. And we get very similar results to the shots. Now, again, this is very specific to the eye, but I've had spectacular success allowing patients to become less sensitive to their allergies, less inflammation, therefore less dryness. Let's talk a little bit about the eyelids. The meibomian glands, the oil glands, rim our lid margin. And these oil glands can become blocked with time. The oil can solidify. Sometimes when the oil solidifies and a little bacteria gets in there, we'll develop a sty. So recurrent styes can be an early sign of dry eye. One of the ways to get the eyelids back into shape is to get those oil glands functioning. First, we have to melt the butter. We have to liquefy the oil again. So we do use heat when the oil is solidified. And you would need 10 to 15 minutes of continuous heat. A lot of patients tell me, well, I use a washcloth in the shower, but that doesn't cut it. It cools down too quickly. It's just not long enough. So I do recommend specific masks. We'll get to that in a minute. In the office, I can also do a procedure called a BlephX. And the BlephX will actually scrub all the debris and excavate some of the solidified oil from the glands, allowing the glands to become more functional faster. So patients with significant meibomian gland dysfunction, we have a way to right that wrong pretty quickly that will remove all the debris and hopefully get those lids functioning normally. When the lid margin is cleaned up, I can actually put pressure on the glands themselves. And this is a great image of where the glands are running vertically up and down the lids. And we can express what's left of the solidified oil so that new oil as it's formed can be secreted normally. This is something, I do in the office. It's not the most comfortable procedure, but it's not terrible and very, very effective. There we go. This is the mask I was talking about. And I actually did some research with the National Institute of Health that really yielded this as a top option for liquefying solidified oil in a gland. A Bruder mask uses what are called medi-beads to emit sterile, moist heat. And it does hold the heat for about 15 minutes. So it's a great option. I highly recommend, at bare minimum, anything microwavable over the counter, but I do love the Bruder mask. I use it myself, and it does improve meibomian gland oil secretion and really yield relief for patients. There's another instrument called the LipiFlow, and I have not brought this into the office. It's been around for a while, and this is a computer-based machine that uses compression. So it's basically a combination of a gland expression and heat at the same time. And it will heat your oil glands from the inside. So in this image, you can see that there is a device placed inside your eyelids against the globe. And then there is an expression device on the outside. So as it heats, it simultaneously expresses the solidified oil. There is a high success rate to this, and several practices in the area have brought it in. But frequently I see that after patients have a LipiFlow, they don't maintain the results and they end up needing another one in good time. So I am more a proponent of developing a good habit and doing a heat and a lid scrub. That would probably yield better results in many cases than doing a LipiFlow once and hoping for the best forever. There is, of course, no cure for dry eye. What we look for is a way to minimize symptoms and keep you comfortable with minimal intervention. This one's a little icky, but it's great. One of the most common causes of discomfort in the lids is something called Demodex. Demodex are in the mite family. They are microscopic lice that live in our eyelashes, and it's incredibly common. I think the percentage I read most recently was 65% of people over 65 actually suffer from this. And sometimes you'll get kind of an itchy lid margin, something along those lines. And like lice, they can be killed with a super dilution of tea tree oil. So we certainly don't want to go put tea tree oil in our eyes, but they do make scrubs that have the appropriate dilution. In this case, I have an image of Oust, which is a dilution of tea tree oil and some other oils that eliminate these tiny little buggers that cause the irritation. Once we have the tear film stabilized, meaning that the oil glands are working well, we have a good oil layer. If you're still experiencing dry eye symptoms and there's not enough liquid staying in the eyes, we can turn to something called punctal plugs. Each eye has 4 drains, 2 in each inner corner of the eye, one upper and one lower in each eye. And we can insert little tiny tub stoppers into those drains so that we can keep the moisture from leaving the eye. We keep the natural tears you make as well as the tears that you produce in the eye longer. These can be made of either collagen or silicone. Collagen plugs are dissolvable. So we can put them in and they will dissolve anywhere from 3 days to 10 days to 6 months, depending on the level of plug that we use. So frequently I like to start with a collagen plug to make sure that it's something that works for my patient. And if they like it, we can move on to a permanent plug or a silicone plug that doesn't dissolve. Now, permanent does not mean forever. It simply means it won't dissolve. They're easily removable. Either way, in both cases, they keep tears in the eyes longer and give relief. This is a picture of the inside corner of a left eye, and you can see in that lower drain, there's a permanent plug. The permanent plugs have a little mushroom head that you can see sitting on top, which is why they're so easily removed. But you don't feel it, and they keep the tears in the eyes longer. There is nothing better than our own tears if we can get them healthy and stable. If we're still not making enough tears, we can look into the medication world. And I do tend, and except in very specific cases like autoimmune disease, to save medication as a last line resort. Medications are something you will likely be on forever once you're on these medications. So the one that's been around forever is Restasis. Restasis used to come in little individual vials. They're transitioning to a multi-dose bottle, although the vials are still available. And Restasis is a medication called cyclosporin A. It is, at its heart, an anti-inflammatory medication. Dry eye causes inflammation. And with this drug, not only does it reduce the inflammation in the tears and at the surface of the eye, but it also causes you to produce more of your natural tears. Now, Restasis takes a while to work. It builds slowly in the system, reaching an effective dose at about the 6-month mark. Most of these dry eye medications are not cheap, which is another reason I save them for later. But they do work well. If you're willing to use it diligently for 6 months, you will start to feel relief. New to the party is Xiidra. And there are a few other drugs that I will add to this presentation that are brand new on the market, but they are all in the same class. They're all anti-inflammatory. So Xiidra is lifitegrast. Similarly, it works at the level of the inflammation, but Xiidra works a little bit further downstream. So Xiidra works a little faster. Typically, in the case of Xiidra, we see results in 2 to 4 weeks. We'll start to have our patients feeling some relief, which is nice. Although as a newer drug, it is, of course, more expensive. There are some other options on the market, and this is one of them. This one makes me giggle, but I have been asked about it a few times. And this is called TruTear. Those 2 little prongs that you see there go up the nose, and they stimulate a facial nerve that causes you to tear. What's nice about it, though, is they're not watery emotional tears. This isn't something that hurts. It feels almost like a TENS unit, if you've ever used a TENS unit on a sore muscle, which is mild electric stimulation of a muscle to relieve pain. In this case, it's mild electric stimulation of a facial nerve up your nose that causes tearing. But the tears that it produces are actually the same quality as normal tearing, not the watery emotional tears that don't make you feel any better. So while it sounds a little strange, it does work. Again, I've seen this device in probably the $600 to $800 range. So it is an investment for patients that want to make it, but if they find they like it and it works for some patients, it's worth it. There's a lot out there on the market these days. A lot of advertising for our dry eye patients. I'm pleased that we're finally getting the look that we deserve from the science. Finally, we get to Procara. For patients with severe dry eye that have damage to the surface of their eye, Procara and amniotic tissues, dry tissues like it, actually replace the damaged tissue on the cornea with stem cells. Amniotic tissue is stem cells that can become like any tissue you put near them. So stem cells are magical in that way. If we put stem cells next to damaged corneal tissue, it will transition into fantastic new corneal cells that are healthy and make you feel a lot better. So in severe cases, we have the ability to use amniotic tissue to heal the cornea and stabilize the tear film. Procaras specifically are also approved for severe infections, bad scratches on the eye. And what's nice is in the use of stem cells, we see less inflammation, which is a big problem in dry eye, as well as decreased pain and quicker healing time. So we like that a lot. And that brings me to the end of our little dry eye talk. I am certainly open to answering some questions if there are any.
All right, guys, go ahead and take this opportunity for questions. Real quickly, Dr. Alessi, what drove your passion for this dry eyes? You can definitely tell that you have a passion for it. So tell us a little bit about your personal experience, if you don't mind, while the questions start coming in.
Sure. When I was much younger, in my early 20s, I was actually diagnosed with a corneal dystrophy, and it didn't affect my vision at all, but it caused some pretty severe dry eye symptoms. And I tried everything. At that point, I was in optometry school, so I was lucky enough to get an answer right away as to what the cause was, but there wasn't a good treatment. And it took a long time to develop a protocol for myself that would keep me comfortable because I couldn't do my own exam. I was just guessing. But once I found it and I found that I could get relief, I really wanted to help patients that were suffering in the same way. Discomfort with dry eye can be severe, and there is relief. There is a light at the end of the tunnel. So it's nice to be able to share that.
Perfect. Do have a couple of questions here. If someone has had cataract surgery previously, can they have a second cataract surgery to improve sight? And then can you also recommend an over-the-counter drop for dry eyes?
Okay, let's look at that. So cataract surgery, we really recommend only be done once. We can go in and put what's called a piggyback or a second implant into the eye if there is a problem, and you can exchange an implant. However, we reserve those typically for problems, poor adaptation to a lens, not just sight correction. If sight correction is the goal, there are still options, though, like laser vision correction to improve distance and potentially also near vision. It would just depend on the goal. Generally, though, if it's avoidable, you don't want to go back into the eye for a second cataract, a lens exchange, or a piggyback if it can be avoided. That's not recommended. I think there's just more harm that can happen than benefit. As far as over-the-counter drops, there are fabulous brands out there, and they're coming out with new drops every day. My general rule, if I haven't seen the eye and I don't know what's going on with the tear film, is the number one rule: if it burns, it's not for you. If it burns, you are allergic to the preservative in that drop, either change brands, trying to change preservative, or switch to preservative-free drops. I have patients who swear by everything from TheraTears and Cysteine to the Equate version from Walgreens. It's really just about finding a comfortable brand for yourself. I like Cysteine myself. When I examine a patient, though, I can typically look at the tear film and make a recommendation of what should be included in the tears as far as supplementation of specific layers, depending on what's missing. So I guess my answer is got to give them a try and make sure they don't burn.
Thank you so much. Also, too, I've got a couple people. I've got Lorraine. I've got Mary. We have individuals that are out there that are sharing that they do experience dry eye. So, as you were saying, we're not alone, and it does happen very commonly. Mary states that she's used heat with OcuSoft to clean the lid, and that seems to work. So, I just wanted to share that.
Absolutely.
Let's see, after cataract surgery, what kind of drops must be put in the eyes, and then how often and for how long?
After cataract surgery, we typically want to put in an antibiotic, a steroid, and a non-steroidal anti-inflammatory. So 3 drops are going into the eye. And if you're using them as individual entities, they're all on a different dosage structure. So you'll probably use the antibiotic for between 1 and 2 weeks. The non-steroidal anti-inflammatory, again, 1 to 2 weeks. And the steroid, you're typically on for about a month after surgery because there's a taper involved. You go from a higher dose to a lower dose. Now today, there are a couple of different drop options available. What we offer, in addition to regular or prescribed drugs to your pharmacy, is a compounded bottle that includes all 3 of those drops. So you're only putting 1 drop of this compound with all the medications in it in your eye. For the first 2 weeks after surgery, you'd use that 4 times a day, breakfast, lunch, dinner, bedtime. And 2 weeks later, you could reduce it to twice a day. So you'll still use it for a total of a month with a taper in the middle. There is in existence what they call dropless surgery, where the surgeon injects the medication into the eye after cataract surgery. The research is good and positive, but they are still seeing a slightly higher incidence of something called macular edema after surgery. So in our area, there are surgeons that will do just dropless surgery. We are not fully convinced here at Collins Vision that that's the best decision for our patients. So we will use some medication in the eye after surgery, but we will combine it typically with the combo drops at bare minimum.
Thank you. And then what, in your experience, is the best allergy eye drop?
For over-the-counter allergy eye drops, my personal favorites and what I recommend to patients, the first one is Zaditor, Zaditor. It's been around forever. I get very few complaints about burning or irritation with it. It's dosed at twice a day. And a new one to market, it used to be a prescription strength allergy eye drop, is called Patanol or Pat-a-Day. And that is dosed once or twice a day, depending on which version of it you're able to find over the counter. Both are fabulous. They work really, really well. And I say whichever one's on sale, they'll do the trick.
Thank you. And, as we all get older, we do know that there are effects to aging. So in your experience, what are some things that we can do from a health and wellness standpoint that we can decrease the effects of the aging as it relates to our eyes, keep our eyes healthy?
Excellent question. The most important thing in Florida is sun protection. Both before and after cataract surgery, those UV rays will expedite the rate of cataract development. And once cataract surgery is done, when the cataract is gone and it's not absorbing that UV for your eye, that UV damage is going straight back to your retina and can actually speed along the process of macular degeneration if you're so prone. In addition to good 100% UV protected, and I like to recommend polarized, given how much rain we have and that we're all out on the water, sunglasses, I also recommend eye vitamins. If you're a patient who's been diagnosed with mild to moderate macular degeneration, there is something called the AREDS 2, AREDS, and the number 2 formula that can slow and in some cases reverse some of the mild to moderate signs of macular degeneration. If you have family history or if you are just aging like the rest of us, there is a formulation called Ocuvite 50 Plus, and it has the important pigments, lutein, zeaxanthin, in them that can help be preventative, but not in such high doses as the AREDS 2 formula. So it's a wonderful thing to take. In addition to that, all the good stuff we all do. Don't smoke, avoid it at all costs, eat your leafy greens, and that'll do the trick.
I love it. Eat your leafy greens. So great advice. Another question coming in, is it worth it to use the OcuSoft each day as an eyelid cleaner?
If you have been told that you have meibomian gland dysfunction, or if you're a patient with ocular rosacea, absolutely. If the oil glands are the issue, especially the formulation OcuSoft Plus, which is in the light blue box, that positive antibacterial. The normal bacteria on our skin, Staph epidermidis, is gram-positive, and it can overgrow around our eyes and cause some of the issues with our lid margin. the OcuSoft Plus can debulk that bacteria and actually really improve symptoms. When I start patients on a regimen like that, I typically start them at twice a day until we get them healthy. And then I recommend they do it once a day or maybe 3 times a week in order to maintain. Because once you're better, it can come back if it's not maintained.
Thank you. The questions have kind of calmed down. I'm getting a lot of comments. Great presentation. So I'm going to give you guys a couple more seconds here to submit those last minute questions. But Dr. Alessi, any other words of wisdom, anything else maybe that you want to share before we, or while they're finishing up with their questions?
Thank you, sure. You know, I'm of the opinion that no matter what your age, you should see well and feel good. So if you are not seeing well or your eyes are not feeling their best, that is a problem we should be able to solve. The excuse should never be, well, I'm just getting old, I'm going to live with it. We want you to have the best possible quality of life. So don't be afraid to ask the questions when you see your doctors. Don't be afraid to seek a second opinion. You know, we want everybody to stay healthy and well.
Thank you. Great words of wisdom. So with that, everyone, I just wanted to have you check your inbox. We are going to send a survey out to you, and please provide us your feedback. We want to share that with Collins Vision. Also, let us know what your topics of interest are. We'd love to have Dr. Alessi back again, so that way we can present what your topics of interest are. And then, of course, if you are interested in getting an appointment, please either let us know, reach out to them directly, and we would be happy to connect you with Dr. Alessi or one of the other physicians in the office. So with that, I got another great presentation, and thank you, Doctor, from Denise. So with that, Dr. Alessi, thank you so much for coming out and taking time out of your busy schedule today. We appreciate that, and thank you to our attendees that joined us this afternoon. And to use her words, stay out of the sun, eat your green leafy vegetables, and we will see you at the next virtual event. So have a great day, everyone, and we will see you soon. Have a healthy day.